Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fardon, and I'm the chair and organizer of Grand Rounds here in Dundee. Welcome to you all. This is our first Grand Rounds of the autumn semester, as it were, and I'm very pleased that we're kicking off with Professor Chim Laing from the Division of Medicine and Cardiovascular Research, who has asked me a little while ago if he could have a talk where he could talk about his research and the research area into SGLT2, which has been done by some of his research fellows and his team. He tells me that it's going to revolutionize how we treat heart failure and diabetes and also renal failure. So I'm looking forward to hearing him speak. Now, if you are sat here thinking that you're desperate to come and speak at Grand Rounds, then please let me know. I've got some slots available at the end of November and into December. But after my plea over email this week, I've filled in a number of slots, so it's looking like an exciting program. Just to give you an idea of what's coming up, you'll know, I'm sure, that this month, October, is Black History Month, and the university is celebrating this with a number of talks that are going on throughout the whole of the university. But we've been asked if we could focus Grand Rounds towards issues which disproportionately affect Black people and other minority ethnic groups. So on the 15th of October, Leslie Crichton, who's our local lead for global citizenship, is going to talk about the global citizenship and her time she spent in Africa and some of the challenges that are faced for Africans. And then the following week, my team here in respiratory medicine with my colleagues, we're going to talk about asthma and lung cancer, two diseases which disproportionately affect Black people particularly. And then we have one of our obstetric colleagues speaking on the 29th about the obstetric complications, which are more common in Black people. Following on from that, we're going to have acute medicine are going to speak about high sensitivity troponin I testing. We have the DCAT annual lecture chaired by Professor Ewan Pearson. He's not told me the title yet or the speaker, so I'll let you know as soon as I know. And the rest of the slots yet to be filled. So if you have something you want to talk about, please let me know. Back to today's slot. Chim has already sent me his video. So what we're going to do, and this is a bit of a first for us, is I'm going to share his video. We'll go through it, and then he's available in his office to take questions thereafter. So we're just going to see how this goes. So bear with me whilst I share the right screen. And ideally, if people could just nod at me or send me a message to tell me that it's working, that would be ideal. So on we go.
Good afternoon. I'm very grateful to Tom for giving me the opportunity to speak to you today at Grand Rounds. My brief is on diabetes and heart failure. And what I'd like to do this afternoon is to share with you some new insights into the pathophysiology and also the treatment of this disease combination. And much of this new insights have come from the many research fellows and MD and PhD students that have been with us. These are my conflict of interest. And we've been interested in this disease combination for quite a number of years. And it's really underpinned by the figures here shown here. It is a common disease combination. The prevalence of diabetes in patients in heart failure in the general population ranges from 10 to 30%, but in hospitalized patients, the prevalence increases. More importantly, this is a lethal disease combination, and this slide shows it very well here. If you have diabetes and you're free of heart failure, you do pretty well. But the moment you develop new onset, new incident heart failure, then your survival rate decreases substantially. So it is a common and lethal disease combination. We believe that what is needed is a better understanding of the pathophysiology, because if you understand the pathophysiology, you're able to define therapeutic strategies. And what we've done here in Dundee is to capitalize on the strengths in Dundee, particularly around electronic health records, linking it to bank DNA to bioresource, using that information to work with the basic scientists, and then to translate the findings from basic science into clinical use through proof of concept or proof of principle studies. So one of the questions I suppose we ask is how important is glycemic control in the pathophysiology of heart failure in diabetes? Intuitively, you think glycemic control is ever so important. Until recently, we've been shown slides like this, and this is from the ARIC data, and it shows that for each 1% elevation in HbA1c, there was a 15% increase in risk of heart failure. But when you look at this data from ARIC more carefully, this was based on one single HbA1c drawn when patients were recruited into the study. And you and I know that this is not ideal. What you do need is more extended longitudinal assessment of HbA1c and glycemic control. And we're also reminded that actually intense glycemic control may not all be good. As shown here in the cohort study, there was a hazard ratio of 1.22. So a ratio, so a 22% increase in risk of non-fatal MI, non-fatal stroke, and CVD death in those patients with very intense glycemic control. And we know that intense glycemic control, there are issues related to severe hypoglycemia, and there are cardiac consequences to hypoglycemia. So what we have in Tayside and in Scotland are record linkage data. It should be noted that much of that early work on record linkage was started by Professor McDevitt and Professor Tom McDonald at MEMO, and that their work has been crucial. And what it shows, and it's since been evolved, that actually link health records can commence from birth up to death, and we're particularly interested in this setting, the laboratory and hospital missions. More recently, we've linked this data to imaging, to echo data, and also to cardiac MRI data shown here. So this is what we did. We linked the laboratory data for HbA1c, and then we looked at echocardiogram and to diagnosis to look at incident heart failure. And this work was done by one of my MD students. This is Helen Perry. She's now a consultant cardiologist at Leeds into adult congenital heart disease. And in her MD, she looked at time-updated analysis of longitudinal HbA1c and risk of incident heart failure. And what she showed very nicely is there was a U-shaped relationship, i.e., yes, if you're poor glycemic control greater than 8, greater than 9, greater than 10, you do get more incident heart failure. But if your HbA1c is less than 6, there's actually an increase in risk as well. So there is a sweet spot. Helen was also interested to see whether there was a genetic basis for heart failure development in diabetes or left ventricular hypertrophy. Certainly from studies, from family studies, there's an evidence to suggest that LV mass, there may be heritability. So what she did next was to link with a very powerful data source, the GODAS data. These are all diabetic individuals who've provided their DNA for research. GODAS being a huge bioresource for research here in Dundee. So linking that data with the LVH data, she was able to show that there are genetic variants that predict left ventricular hypertrophy in the diabetic population. What Helen did was, by linking up that data, that allowed us to expand our linkage of heart failure data to other bank bioresources. Besides GoDarts, we were able to secure an European grant and to do the biostat study in heart failure, and that provided about 4,000 heart failure cases. And more recently, we've been looking at the GoShare project to link that up with diabetes individuals, but also with heart failure. And equipped with this, we are able to join arguably one of the largest genetics of heart failure consortium, the HERMES Consortium. We're now part of the executive committee as well as the steering committee. And you can see here a very powerful resource of 47,000 heart failure cases and close to 1 million control. And Ifi Modi secured a chief scientist NES fellowship lectureship, and this allowed him to look into and learn about the use of Mendelian randomization to see if you can identify biomarkers for target modulation. We've just recently published in Nature Communications the finding of the genome-wide association and MR analysis in the pathogenesis of heart failure. 12 independent variants at 12 genomic loci have been identified. In the MR analysis, we've shown that it is independent of coronary artery disease, the potential role of BMI, blood pressure, and atrial fibrillation. Focusing on pathophysiology, this is a slide from Michael McDonald from Glasgow. It shows what are the potential pathways that leads to heart failure in diabetes. And I've highlighted here the interest around fibrosis and of insulin resistance. And it has been proposed that actually fibrosis may lead to insulin resistance. And this is work done by Dr. Lee Kang here in Dundee, and she has a mouse model, a high-fat mouse model that leads to accumulation of collagen, and this collagen could actually be a barrier for insulin action and causes insulin resistance. So Lee Kang, working with her, we've secured a British Heart Foundation grant, which we're interested in what happens to collagen formation in the high-fat diet. And you can see on this slide, in the high-fat diet, loads of these collagen accumulation. What she was able to show was, if you introduce an anti-fibrotic agent, she was initially looking at hyaluronidase, and that was able to show an improvement in insulin sensitivity. Obviously, her work is of huge interest because there may be a role for other anti-fibrotic agents, such as pirfenidone, which is currently used to treat patients with idiopathic pulmonary fibrosis. Staying on pathophysiology, there's also a lot of interest around diabetic microangiopathy, microvascular dysfunction. And I borrowed this slide from Jared Butler, and what he's shown in his group is that microvascular dysfunction may play an important role in diabetic cardiomyopathy and also in heart failure with preserved ejection fraction. So small vessel function could potentially be important. And Ifi recently has published this, and he's looked at the microvascular disease burden amongst our diabetic individuals, i.e. in retinopathy, neuropathy, and nephropathy. And he was able to show that microvascular disease actually adds to the risk of the development of heart failure, both heart failure with reduced ejection fraction, as well as heart failure with preserved ejection fraction. And looking beyond that assessment of neuropathy, nephropathy, and retinopathy, I'd like to draw your attention to diabetic retinopathy and the use of artificial intelligence. So on that note, Professor Emmanuel Trucco, a computer scientist from Dundee, he and colleagues in Edinburgh had developed this machine learning of retinal images called the Vampire program. And that is a very powerful tool because using machine learning and all those vessels available to be analyzed, I think is a fantastic tool. And using this data, IFI together with Manuel Trucco was able to show that measures of venous tortuosity and fractal dimension in the retinal vessels actually relates to heart failure outcomes. We had used this data to seek funding and was able to secure, together with a huge consortium across Europe, and an EB Horizon 2020 grant amounting to 23 million combined with funding from the industry to look at diabetic cardiomyopathy, and we're leading the work package on the retinal vessel assessment. I now want to move on from pathophysiology to treatment of diabetes. And we also ask the same question: is glycemic control important in patients who've developed diabetic patients who've developed heart failure? And this was work done by Dougie Elder, my colleague, when he was an MD student, and he reported again a U-shaped relationship between HbA1c and outcome in patients with both diabetes and heart failure. So i.e. don't want to be too intense glycemic control, particularly in these patients that are often frail and elderly. And it's important to note that this work has been picked up by clinical practice guidelines. And I think that's important. It highlights that observational data, when it's powerful like this, can be used by clinical practice guidelines for practice. So there's a real impact on day-to-day clinical practice. What we also found with Dougie was that in that U-shaped relationship, in those patients with HbA1c of less than 7, there were more use of certain drugs like sulfonylureas, insulin, and TZDs. And I think that's where there is a treatment conundrum, that some of the drugs that we use to treat diabetes are often not suitable if the patient developed heart failure. And for example, TZDs, and as shown in this meta-analysis, TZDs are associated with an increase in risk of heart failure. The reason for that may be an off-target effect that leads to fluid retention, and at this moment, it should not be used in patients with functional class 3 to 4 heart failure. There's also data like this from the UK General Practice Research Database that shows that the use of sulfonylureas, there was a 46% risk of first episode of heart failure. So TZDs, sulfonylureas. And how about metformin? Well, historically, there had been concerns about lactic acidosis, but when you do a systematic review around this, there are hardly any, no cases of fatal or non-fatal lactic acidosis. So we again use our data set and record linkage to look at this, to see if metformin use, is it safe or is it not safe? And what we showed and reported this almost 10 years ago was the use of metformin or alone or in combination was associated with a 30% lower risk of mortality. And since then, other groups have found this, and we've done a meta-analysis of 34,000 patients with heart failure and diabetes who use metformin, and it shows it's associated with reduced mortality. So when we published that a while back, it was initially picked up again by clinical practice guidelines initially, from the Australian guidelines, and more recently, this Dougie Elder's paper continued to be cited in the more contemporary guidelines from North America. So this metformin finding was for us, I think, was an interesting observation, but it prompted us with other scientists, and in this case, Graham Reiner, to explore the possibility that maybe metformin could be repurposed for cardiovascular diseases. And this was because we've seen work like this, where metformin in animal studies have been shown to prevent the progression of heart failure and improve cardiac pump function. And this prompted us to further explore this, and Graham Reiner was particularly interested in the anti-inflammatory effect of metformin. And his PhD, Amy Cameron, worked on this and in cell lines was able to show that metformin had anti-inflammatory effects. We were able to demonstrate this in a human setting to show that plasma cytokine levels were also reduced. And Amy Cameron won the American Heart Association Best Manuscript Prize for her work. But I think the fast emerging is metformin is a complex drug acting on a lot of different organs, and potentially, as shown on this slide, there may be pathways that it could benefit patients with cardiovascular disease. So therefore, metformin, we would love to do a trial in patients with heart failure and diabetes, but because of that earlier work showing that metformin in observational study is safe and could be beneficial, it's almost impossible to do a trial of metformin in heart failure and diabetes because almost all patients are on metformin. But we wonder whether metformin could be used in patients who are at risk of heart failure, such as patients with insulin resistance, with at-risk heart failure or pre-diabetes. And this is work done by another PhD student, Matluba Azad-Jali, who's now a consultant cardiologist in Muscat in Oman. And in her work, she showed that 61% of patients, and these are non-diabetic heart failure patients, have insulin resistance. And these patients often don't feel well, they have exercise intolerance, and we think it could be a new target for therapy for, say, a drug like metformin. And this was, in fact, the work done by Dr. Aaron Wong when he was a BHF-funded fellow. He's now a consulting cardiologist in Bridgend in Wales, and he conducted the first proof-of-concept study of metformin in these heart failure patients. Although we didn't reach our primary endpoint of peak VO2, he was able to show that metformin caused patients to reduce weight by 2 kilograms and improve their exercise respiratory parameters, which are of interest. And of course, we've moved on to focus now on left ventricular hypertrophy. Prof. Struthers has always been interested in LVH. And then Ben Swieczkowski, working with us as an MD student, had shown that allopurinol, the gout medicine, was able to regress left ventricular hypertrophy in type 2 diabetic individuals. So focusing on left ventricular hypertrophy, we recently published a MET remodel study done by Mohabbatri Mohan, who's currently a postdoc in Warwick. And he did the MET remodel study, and he showed that was funded by the British Heart Foundation. And he was able to show that metformin improved the left ventricular mass index. So left ventricular hypertrophy is an interesting phenotype, as we recognize as an independent predictor of poor outcome, but it also leads to a condition called heart failure with preserved ejection fraction. And heart failure with preserved ejection fraction is an unmet need because at this moment, there's no evidence-based treatment for it. It has a complex pathophysiology. I borrowed this slide from Caroline Lamb, highlighting what is the current thinking of the different mechanisms involved. Because it's such a complex pathophysiology, it may need a complex intervention. And on that note, we wondered whether metformin might be beneficial. There's certainly reported effects on certainly the cardiometabolic abnormalities, microvascular inflammation, maybe some fibrosis, and even, in fact, it reduces pulmonary hypertension. So we do need a trial of metformin, the MET-HFpEF trial. We're building a research team at this moment with IFI, involving colleagues in Malaya, and also in Singapore at Duke and US. I want to focus next on the new kid of the block, the SGLT2 inhibitors, a new diabetic compound. So SGLT2 inhibitors are drugs that block glucose reabsorption in the proximal tubule, and therefore patients are able to increase their glucose excretion. As it does this, it lowers blood glucose, but because it also increases water excretion, it could also potentially lower blood pressure, and there are other potential effects. Patients will also lose weight because of increase in urinary caloric loss. And there's been immense interest in this class of drugs, driven by this first of many cardiovascular outcome trials of SGLT2 inhibitors. This is the EMPEREG study. And this was an amazing study when published because it showed that empagliflozin had a decreased cumulative incidence of death from cardiovascular sources. And in package, as you can see from the survival curve, it separates very, very early on. And in that EMPEREG study, they showed that a lot of that effects relates to heart failure hospitalization. Again, these curves diverge very, very early. And that work from then onwards has shown that other SGLT2 also share these effects on heart failure. And more recently, Professor John McMurray, who's based in Glasgow, was a fellow here in Dundee, led the DAPA heart failure study that showed that the dapagliflozin SGLT2 also helped patients with heart failure. And this is the DAPA heart failure study, reached the primary endpoint, a significant effect on worsening heart failure event, 30% reduction. And what was interesting is the effect was also seen in patients who did not have diabetes. So potentially SGLT2 inhibitors could be useful to treat patients with heart failure. Because of that, there's been immense interest in the mechanism by which SGLT2 have this benefit effect on the heart. In fact, there's now data to suggest that it's also protective for the kidneys. And we've been interested in this for a long time. In fact, we were interested in this before EMPEREG came out. We got funding for this from the European Federation for the Study of Diabetes, EFSD, to study reform. This is looking at dapagliflozin on LV remodeling measured by cardiac MRI. This was done by Jagdeep, who's currently an ST trainee in cardiology in Edinburgh. After EMPEREG came out, we were confronted by many funders to do further research on this. We got funded through AstraZeneca to see if dapagliflozin could regress left ventricular hypertrophy. Alex Brown, who is a newly appointed consultant cardiologist in Newcastle, did this work and was able to show that dapagliflozin regressed left ventricular hypertrophy, which really provides a new insight into how this class of drugs work. He also published this data very recently in JACC-CV imaging, showing that dapagliflozin also improved LV longitudinal function in type 2 individuals. One other condition we were also interested in is in patients like this who come into our ward with decompensated heart failure, with gross edema, and they develop diuretic resistance. And in those settings, we often give them a thiazide diuretic, in which case they do lose water, but they also end up losing a lot of potassium and a lot of sodium. And we wondered whether SGLT2 might work. And we saw this case report then in about 5 years ago, where epagliflozin help diuresis in a patient, one single patient case report with acute decompensated heart failure. Look at the curve in blue. That patient started to pee for Japan. So we then approached the British Heart Foundation and we got funded for the RECEIPT heart failure study. This is a double-blind, randomized crossover study where we looked at the renal effects of SGLT2 together with loop diuretics. And we've just published this. Natalie, working with IFI, did a fantastic job on this study and showed that actually what the SGLT2 and empagliflozin does was to increase free water excretion it could be losing the sort of fluid that we are worried about, third spacing interstitial fluid. So I've covered a lot of ground. I've shared with you the work done by our research fellows and MD and PhD students across the whole spectrum of translational research, from basic science, using informatics, proof of principle studies, and using imaging and physiological techniques. So in summary, the work would address on this common and lethal problem. We provided new insights into the pathophysiology, a U-shaped relationship between HbA1c and incident heart failure and outcomes. There's a lot of work still going on around genetics of heart failure. There's basic science research around fibrosis and insulin resistance in the heart. I think what is also exciting is the work being done on microvascular dysfunction and the potential use of machine learning and AI research around it. In terms of treatment, we provided evidence that metformin is not only safe but potentially good. It's also suitable for repurposing potentially in the unmet need of heart failure with preserved ejection fraction. SGLT2, I think, is an exciting class of drug. We think it might be good now for heart failure irrespective of diabetes status. I think we need to still continue to try and understand the mechanism of action of SGLT2, because if you understand the mechanism, you might reveal new therapeutic strategies. I'd like to pay tribute to all the fellows, and many of them have actually gone on to win prizes both nationally and internationally. I'm also very, very grateful to all my collaborators across Dundee, including my NHS colleagues across the United Kingdom. I've got, not in our space, a lot of international collaborators as we're part of many, many consortium. And finally, I'm also very grateful to all the patient volunteers and to my funders. Thank you very much. Thank you.
Right. Okay. So we move from seeing Chim in his office in his scrubs to Chim in his office in his shirt and tie. That all worked. Hopefully, everyone saw the video, and it was all as you say, Chim, gremlin free. Now, I found that absolutely fascinating stuff. I think it's a really, really good journey through a number of research fellows under your stewardship and Alan Struthers as well. To show that the direction of research here it's not random. This is a clear path of decision making to reach the end goal of treating heart failure, and I really enjoyed what you had to say. I thought it was excellent. So has anybody got any questions? I'll just open my chat window. Graham Lease, interesting, the U-shaped relationship with HbA1c is the same for several other outcomes in diabetes. I wonder if, are you there, Graham? So you want to just perhaps expand on that, or we just... I see Rory has turned his camera on. Usually means he wants to say something.
Okay. By the way, I put on this tie just for this. I've been in scrubs for 6 months now. I haven't worn this tie for 6 months, so there you go.
You're such a rebel, Chim, wearing it.
Let's go to Rory first, and then maybe we can catch Graham.
Chim, you'd be aware there's been a lot of changes in guidelines, in both in the diabetes and the cardiology guidelines over the last few years, and they're gradually coming together. But there was quite an explosive guideline that came out from the European Society of Cardiology in 2019, which advocated SGLT1 inhibitors, GLP-1 receptor agonists, as first-line therapy before metformin in type 2 diabetes. And that was obviously very different from the ADA ESD guidelines. And I wonder what you thought about the evidence base for that.
Yeah, so that is a great question, and it's something that I get asked a lot on platforms and in webinars like this. So I think it's important to note that what drove the ESC guidelines were these randomized control trials. But we also know that many of these SGLT2 randomized control trials was on top of metformin. The only data around metformin is really just observational data. So therefore, that kind of forced the ESC, prompted the ESC to change that recommendation. But since the publication of that European guidelines, there's been a huge number of responses, including from the Americans, to say, hang on, you're still I think metformin still holds a very special place. So recently, we just written a review article, Graham Reader, Iffy, and myself, and we'll be publishing this to talk about this equipoise. We do need a trial, but unfortunately, the trial is never going to be done, you see, of metformin versus SGLT2. That's going to be hard. In my talks around the country, a lot of diabetologists are still sticking to metformin as the first line, I think. So that's very controversial when it came out. Thanks.
Can I ask another question?
Sure.
Of course you can.
So, Jim, the SGLT2 inhibitors are likely, therefore, to be prescribed by cardiologists, particularly in people on the wards. They are not without risk. And so I'm wondering whether locally we need to think about what guidelines that we provide for the use of SGLT2 inhibitors in this context, and say a diabetic with heart failure. You know. Yeah,
that's another very important practical question. And because the cardiologist will be seeing these patients that are at risk. But we are very mindful that we do need to work with our diabetology colleagues and how best to do it. I know the clinicians are very busy, but whether we can work with the diabetic nurse team, for example, to initiate those prescription. But it's also important, it's not just the cardiologist, because the emerging data is with the renal physicians that this class of drugs is also renally protective. And that's another group of physicians we need to work with. So I'm working with Iqbal Malik, and we're trying to work with Samira as well, maybe across the three specialties to see how best different scenarios, where there's an acute admission, but at the end of the day is also to engage the primary care physicians, because arguably they will also be seeing these at-risk patients. Ultimately, at the end of the day, we want the best for our patients, but as a new class of drugs, we need to know how to use it. There are side effects that we all need to know how to treat: the candidiasis, the balanitis, and also watch out for the DKA. So I think what we don't want is to start using it a lot and then we get a lot of trouble. But having said that, and I've spoken to John McMurray about this, is that when we looked at the DAPA heart failure study, it's very, very well tolerated. And he almost suggested, and he's very enthusiastic, he says, prescribe fire and leave, because he says there are hardly any side effects. He said he hasn't seen it. So we need to work together.
Perhaps, thanks so much, Rory and Chim. Is Graham there again? I'm just intrigued by this U-shaped curve, and perhaps you could just expand a little bit on the other outcomes, which mean that your diabetic control should be good, but perhaps not too good. Yeah, so I mean, I know Rory has, one of the world authorities on hypoglycemia. So I think that U-shaped relationship, we saw it in heart failure. And in a sense, it's when we published it, the group from Minnesota also showed the same thing. So it's been replicated over and over again. So that intense glycemic control
in frailer comorbid patients may be an issue. But I think the general guidance in someone without these comorbidities in young people, I think it may still be a linear relationship. So I think that needs to be looked into.
Graham, have you got any? I see we've got the camera turned at you now.
Yeah, it relates to other outcomes in diabetes too. There has been a hint of that with retinopathy and also foot outcomes in terms of amputation.
Really?
So I suspect you're right, Chim, in that I think a lot of it possibly relates, some of it relates to, as you say, driving HbA1c down to and blood sugars down with risks of hypos or whatever else it might be doing.
Yeah.
But also part of it is low HbA1c is sometimes a marker of frailty and loss of muscle bulk and weight. So it's a sort of a marker rather than necessarily a specific issue for some of these patients. And therefore that's why I would agree with your supposition that perhaps in younger people it is more of a linear relationship. Yeah.
So I think when we look at the guidelines, at least in heart failure, they took this on. They say for the frailer patients, they actually cited our reference for the impact, that it is a U-shaped relationship. But in other younger people, they said maybe then the lower the better. So that's kind of how they tackle that evidence.
Now the other aspect that was discussed earlier with Rory is in terms of adverse events. I suspect the indications are widening rather than narrowing, and you allude to the interesting trials with renal failure. So that there are a number of trials just looking at these drugs in patients with chronic kidney disease with and without diabetes. And there's a suspicion that it'll be a good outcome from those trials too. So before we were restricting our use for these drugs with chronic kidney disease, so that's perhaps going out the window. So I think the indications are probably widening rather than narrowing, although there is the odd group. I mean, the really only major significant adverse event is for the few patients who do get DKA, and if there's some way that we can predict that, that would be helpful. But
yeah, and patients
virtually
with
no absolute contraindications, I don't think.
Except for foot amputation. So if there's a history of foot amputation, at least.
Yeah, I'm not sure about that. There's just one trial with canagliflozin that showed that, and there were other trials with Emper and dapagliflozin have not shown that.
No.
And it may just be a bit of, and it was only related to toe amputations and not major below knee amputations. So it may be just that when you're drying these patients out a little bit with the diuresis of it, a critical vasculature of the toe becomes compromised, and it may just be that. But it's a weak signal of anything, I think. So I think I would say the jury's still out about feet.
Yeah, I agree. I think it was just with Canna, but I think the renal effects are so amazing. I think again, understanding the mechanism of that is a subject of intense research across the world. So Natalie's study, when it was published and picked up, has generated a lot of dialogue because she was able to show very neatly in her study that free water excretion. And that free water excretion is intriguing because at least in heart failure, the third spacing pulmonary edema, the anasarchic patient in interstitial edema is always very troubling. And when we did give them intravenous loop diuretics, we lose a lot of sodium and we lose intravascular volume, and then they go into pre-renal uremia. Potentially what she has shown is that by losing free water, which is what glycosuria does, you draw out water. And as you draw water, then you actually diurese the right type of fluid. So and she's just won the EDTA ERA award from the Scottish Renal Association for her work. And she's going for the Fitzgerald Peale Prize again this year. So I'm boasting about my fellows, but they're doing so well.
You've got every right to boast about your fellows, Chim. I think you've got a really excellent series of fellows that have come through since I've been here. That's in 15 years. I think you've got a lot to be proud about. Anybody else got any questions from the virtual floor? Anyone? So I'd just like to thank you for sending me the video, and I'm glad it all worked out, and thank you for being there in person. Thanks for the audience for coming. Next week is the launch of the Dundee Research and Academic Medicine Student Society, DRAMS, and Rory McCruan, Dean of Medical School, is going to introduce that, and there's a couple of speakers. I think Anna Maria is speaking, is she not, Chim? So, and then the president of the society, Wee Nan, is also going to speak. So I've had some interactions with them already. One of their journal clubs, really excellent throughout, second years through to fourth years, really good stuff. So I'm really excited about that. And then during Grand Rounds, I've had more messages from people saying that they're volunteering to do slots later in the year, including a session on the effects of hypoglycemia. So that's very apposite. So thank you to Rory for messaging me. That'll be the 19th of November. Okay, so thanks very much everyone for being here, and I'll sign off now. See you again next week.
Thank you.
Thanks very much.
Thank you. Thank you. Bye, everybody.